Hello, everyone, and welcome to Journal of Society of Cardiovascular Angiography and Interventions, Conversations in Interventional Cardiology. My name is Sandeep Nathan. I'm a professor of medicine at the University of Chicago Medicine. I serve as an interventional cardiologist and as an associate editor for JSCAI. It's in that capacity and on behalf of Dr. Alexandra Lansky, the editor-in-chief of JSCAI, that I'd like to welcome you to this conversation in interventional cardiology. I'm honored to represent JSCAI today and joined by an esteemed panel of presenters and discussants. First, I'd like to introduce Dr. Saman Saidi from Västerås Hospital, Department of Medical Sciences at Uppsala University in Uppsala, Sweden. Welcome, Saman.
Thank you very much. Thank you for having me.
Dr. Stefan James, professor of cardiology at Uppsala University and former chairman of SCAAR, of the SCAAR registry. Welcome, Stefan.
Thank you very much.
And then last but certainly not least, my good friend, Dr. Timir, who's a professor of medicine at the University of Tennessee Health Sciences Center in Nashville, Tennessee. Welcome.
Thank you.
Okay, wonderful. So we are here today to discuss an important paper that was recently published in JSCAI titled Outcome of Saphenous Vein Graft-PCI Using Contemporary Drug-Eluting Stents, a SCAAR report. And I think, Saman, you'll start us off with a brief presentation and a review of the data as published in JSCAI. So I'll hand it over to you.
Thank you very much for the invitation. I'm privileged to have been given the opportunity to, on behalf of all co-authors, present our paper. We start off with a bit of background. PCI of saphenous vein graft is associated with poor outcome and often regarded as inferior to native vessel PCI. So we investigated the clinical outcomes of saphenous vein graft using contemporary drug-eluting stents in this complete national population. We analyzed the continuous non-selected data from the SCAAR registry, which holds data from all consecutive coronary angiographies and PCR procedures from all 28 Swedish cath labs. All patients in Sweden who underwent saphenous vein graft-PCI of a de novo lesion with a contemporary drug-eluting stent between 2013 and 20 were included in the study. And in the 7-year study period, 3,106 stents were implanted in saphenous vein grafts of 2,198 post-CABG patients. We described the baseline patient and procedure characteristics as well as outcomes. Please allow me to illustrate the characteristics of this high-risk population. The median age was 74 years with male predominance at about 86%. There were high prevalence of classical cardiovascular risk factors. Above 90% had hypertension. Above 90% had hyperlipidemia. Diabetes was high at about 40%. 11% were current smokers and more than 50% had a history of smoking. The majority, nearly 75%, presented with an acute coronary syndrome, where 10% with STEMI and over 50% with non-STEMI. About 45% of the patient have had a previous PCI, and above 65% had previous myocardial infarction as well. Naturally, there were 100% of previous CABG, of course. The vast majority, 96%, had multivessel disease. Almost 30% had left main disease, and the average lesion complexity was high. Saphenous vein graft only PCI was performed in 87%, while a native vessel was stented in 13% of all patients. Concomitant CTO PCI was performed in 4.2%. At 50%, the most common indexed PCI target was an LCX conduit, followed by an RCA conduit about 40%, and an LAD conduit of 20%. Complication rates were low and no procedure-related deaths were reported. So the big picture, this study shows favorable stent-related outcomes for saphenous vein graft-PCI with contemporary drug-eluting stents, while the risk of patient-related adverse clinical outcomes remain high in this context of a high-risk profile population. Please allow me to cover this in a bit more detail. But before I do that, it's worth mentioning that the SCAAR registry receives bi-weekly updates from the National Population Registry, which provides data on vital status and date of death. This gives us a robust endpoint for death, and since the vast majority of MIs are treated in CCU, the follow-up data for new events is close to 100%. Also, any revascularization performed in Sweden is registered in SCAAR, providing reliable follow-up data for that endpoint as well. So with that said, at 3 years, 1/5 of the patient died, 1/5 experienced a new MI, and 1/3 underwent a new revascularization procedure. Diabetes, here in red, was generally associated with higher adverse event rates. This was more evident for clinical outcomes than stent-related events, which indicates that diabetic patient intrinsic factors had more pronounced effect on the hard outcomes rather than saphenous vein graft stent performance. Death rates remained similar regardless of stent burden, reflecting the high-risk profile of the study population, which translates into an overall high clinical event rate. And to the stent-related outcomes, no suitable arm with similar baseline risk could be identified in the SCAAR data set for comparison. So we compared our outcome data to historical data, here with another SCAAR study by Ferrabut and colleagues from 2012, which described the long-term outcomes of drug-eluting and bare metal stents in saphenous vein grafts. So we compared the current data to the outcomes of drug-eluting stents only data from a decade ago. In this study, in blue, at 1 year, stent thrombosis and stent restenosis rates were 1.2 and 3.9, respectively, compared with 1.9 and 7.5 in the study by Ferrabut and colleagues. The corresponding rates for stent thrombosis and in-stent restenosis at 3 years were 2.8 and 9.7 in this study, while around 4% and 20% in the former SCAAR report, suggesting a substantial improvement in long-term stent outcome with contemporary drug-eluting stents. Also, as the threshold to subject a post-CABG patient to angiography has been lowered in the last decade, the observed improvements in rates of stent thrombosis and in-stent restenosis are likely underappreciated. That concludes my summary of analysis. Thank you.
Wonderful. Thank you for that. That's a great capsule summary of this important paper. I have at least a half a dozen questions, but before I monopolize the session here, I'd like to turn it over to Dr. James. Stefan, can you weigh in here as a collaborator and a co-author on this paper? Anything to add or specific call-outs?
Well, the aim of the SCAAR registry, which is a portion, the interventional cardiology portion of the greater Sweetheart registry, the aim is to be able to follow the quality of care. And that's what we're doing here. This is a very descriptive observational study. We cannot draw any causal conclusions how to treat these patients. But I think this is comforting to see. A strength of this paper is that it's completely unselective. All patients for this fairly long period of time have been included, and we can capture all secondary events after the interventional procedure, such as death, myocardial infarction, and repeat revascularization. And so it's very reliable. And I think the patient population is representative of a true clinical practice, could be extrapolated to other countries as well. And it's comforting to see, despite the fact that we know that patients are getting older, sicker, over time, PCI tends to be more complex lesions. And we're always, on an everyday clinical practice, we're struggled with how do we treat these patients with saphenous vein graft stenosis? Should we do them or should we avoid? Should we treat them medically? Should we go for the native vessel or the vein graft? I think this shows that the results from an interventional perspective is pretty good. I think that's relieving to see that we probably should be doing this because these will, of course, the patient outcomes is not ideal for a long period of time, but they're old and sick. But I think we can, make them feel better. We get fairly long-term good results, low risk of restenosis, target lesion revascularization. So I think it's comforting to see that what we do makes a lot of sense, and we should actually be putting these patients at a little bit of risk doing this, but it probably benefits them on the short and long term. So it's comforting to see. That over time also, as compared to the previous study, it looks better over time with improved stent technologies, improved experience, and larger volumes.
Excellent. Thank you for that. Timir, initial thoughts on this paper, and how does this fit in with your practice and sort of the broader practice in the United States?
Yes, I don't think based on this paper, the overall practice will change. Of course, it's a data observational study. There are questions from this paper, especially 13% patients had native basal PCI concomitant, although it's not clear from the paper. Maybe authors can explain more that is it a same time, and is it the same vessel, or is it other vessels? That one question. And also there are almost 13% patient on SVG-to-LAD PCI. We don't know about the Lima on those patients. There was no intravascular sound or any kind of imaging data there. We don't know embolic protection device used or not. Although these patients are very sick, because almost 100% patients present with acute coronary syndrome, and all are high-risk patients, elderly patients, all the risk factors are there. But one thing also strike me that in-stent thrombosis rate is, although lower compared to the previous cohort, but it's still higher. It's pretty 2.8%, almost 3% in-stent thrombosis. I don't know what kind of antiplatelet was used, and also in-stent restenosis is still in 3 years 20% is high compared to any other studies. So these are the common questions or concerns from this study. But I don't think it's a practice changing. We are doing it, but only question is, it would be better if we have a data on native basal PCI versus SVG-PCI. So that would be the more good paper.
I think, thank you for that. I think what struck me about this is that there is sort of a common wisdom that once a vein graft degenerates, it's sort of hopeless. You can fix this, but you're sort of chasing your tail at that point, high risk of stent-related outcomes. And obviously the substrate of these patients are different than patients who don't have vein grafts, as you nicely demonstrated, Saman. These are high-risk patients, 40% diabetic, enriched for ischemic events. What I took away from this is that done right, and I was sort of struck by one line in the paper, many lines, but one that Sweden has basically abandoned the use of bare metal stents as of 2016, which is astounding, because I think that 2,500 cath labs in the United States or so, most of them, a lot of them, still have bare metal stents, and there are certain scenarios where we still sort of cling to bare metal stents like it's some sort of security blanket, it's somehow safer and so forth. And so, with the current generation of drug-eluting stents, which I think we all agree are excellent, uniformly excellent, and mostly using drug-eluting stents that are commonly available in the United States, you've demonstrated fantastic stent-related outcomes, but, the substrate of the patient eventually catches up. I wonder if you could comment a little bit on the use of embolic protection devices, calcium modification, and, as Timir alluded to, intravascular imaging for these interventions. Is that part of routine practice in the SCAAR population?
We do imaging, but it's at the discretion of the operator, really. So if the lesion is, if you need more information, you definitely use imaging. In the study period, the imaging use wasn't that high. It's getting more and more for each year, obviously. Stefan could help me with this, but the distal protection devices, they weren't really used that much in the beginning, and they definitely haven't been used during my time of practice at a PCI lab. So I don't think they're used that much in Sweden at all. We try to look at that in the data, but there are way too few to draw any conclusion or even describe it in a reliable way.
And then just sort of following up on that, this data represents presumably fairly complete data, the likes of which, you know, is really difficult to get in the United States. I mean, we've got CAF-PCI and various other registries, but, you know, that's voluntary participation, and the reporting of it is sometimes, you know, has some missing data and so forth. Can you comment on any secular trends in the practice of PCI in Sweden over the 7 years during which this data was collected? Meaning, have there been any other big changes during that time that explain the improved outcomes? It's not sort of side by side with the non-vein graft data, but you demonstrated in one of the slides you shared with us from a prior publication of SCAAR that numerically outcomes seem to be better. Are there any other big trends? And, you know, again, something that Dr. Paul touched upon is use of antiplatelet therapy. I think that, you know, many parts of Europe were sort of ahead of us in terms of using the more potent P2Y12 inhibitors, you know, routinely in ACS and PCI.
Yes, I mean, one of the strengths of these registries is that we could see the use of dual platelet therapies over time, and they're constantly coming out high. I mean, the whole Sweden adopts the use of dual antiplatelet therapies for acute coronary syndromes, and obviously patients with more chronic lesions, they receive the dual antiplatelet therapies as well, but in a shorter period of time. So they get about around 6 months. Most sites or all sites have adopted, and they're using the latest ones as well as aspirin. So I can't see that's not a big issue in Sweden, really. We use the drugs in all sites.
Yeah, I can fill in a little bit. No, there are no dramatic changes over this period of time. There has always been a consistent use of dual antiplatelet therapy, and with using the potent agents for ACS. The types of drug-eluting stents have, of course, shifted a little bit as new stents have been coming out and new evidence for these have been presented. Distal protection has not been used more than occasionally throughout the whole period of time, while imaging has increased dramatically the last few years. We do have fairly good information about that in the registry as well. So it's possible to look at IVUS and OCT or other physiological measures as well. We haven't done that because the use have shifted. It was not complete in the first period of time. That's something that can be done for longer-term follow-up, including more patients, because now there is a consistent use in approximately, I would say, half of the patients, different types of imaging methodologies. So I think it's a sort of constant evolution of more mature training for more mature interventionalists with very high standards of medical therapy, use of the most updated stats and up-to-date therapy. I think we have shown in many trials that the medical therapy is excellent and the adherence to guidelines is very high.
That's great. Thank you very much for that additional context. Maybe final thoughts, Timir. I'm going to push you a little bit here. Do these data motivate you to do more vein graft PCI as opposed to resorting to CTO PCI or native vessel PCI and just sort of writing off the vein graft? I think that's sort of an important take home for me.
Yeah, I think this is a great question. These particular patients, they presented all are ACS patients. I think because of ACS patient, they don't have any much option to do CT or PCI during that ACS settings. But of course, if you have a stable patients, guidelines say that a native basal PCI is better than the vein graft PCI, and that's kind of a standard now. But again, all the guidelines say there is no really data. That's why I was asking that if in future, if we have some data head to head, like native basal PCI versus graft PCI, at least in stable patients, then we'll have better clarification. But if we go by guidelines, then native basal PCI is better. But because of ACS, I think in ACS settings, you don't, you just open the vein graft and deal with it. And then if they have a CTO, then you can do later on.
Excellent. Well, I think we'll conclude with that. I'd like to thank the presenter as well as the discussants once again, Dr. Saidi, Professor James, Dr. Paul. Thank you so much for joining. And for everyone who tuned in, thank you so much once again for joining us for JSCAI Conversations in Interventional Cardiology.